If you're all right to unmute yourself.
Carlina, cool, I'm here.
Amazing. And I will hand over to you, and Hayley will move the slides along for you.
Can I just check, can you see the slides?
Yeah, we can see the kind of the cover slide, but they've not moved along.
Okay.
That's working. Thank you, Hayley. I'll pass it to Carlina.
Thank you. Ooh. Thank you. Hi, I'm here today with, I think Julie Bose is also here, representing Torbay. I'm hoping she's in the room. I can't see everyone that's in the room. Maybe not. Okay, that's fine. I'll do the slides. I'll do all the slides. Could you please move on to the next slide? Whoever has control of the slides, please. Thank you. Great. Okay, my name's Carlina Hall. I'm from Plymouth City Council, and I was part of the carers project, carers and young carers project for refugee, asylum seeking, migrant and ethnic minority communities in Plymouth, Devon and Torbay. I'll be talking through the slides today. Next slide, please. That's a lovely picture of our Smeaton's Tower in Plymouth, overlooking the Plymouth Sound. Next slide, please. Okay, so it's just a brief overview of the population of Plymouth and Torbay. So we have about 250,000 people in Plymouth, 136,000 in Torbay. We have 27,000 or so carers in Plymouth and 16,000 in Torbay. Obviously, Torbay's been a smaller area, is slightly less diverse in Torbay as well. So we were focusing on different groups within those areas, and actually by joining together, we managed to engage with quite a few number of carers and young carers from those groups that we were targeting. In Plymouth, we have implemented a school survey, annual school survey, and this year we incorporated questions relating to whether the young carers were from ethnic minority groups, refugee or asylum seeking communities as well, which is the first time we've done that, and we'd identified 31 young carers by doing that this year. We hope to continue that next year, and Torbay have taken on the template and they're looking to replicate that in Torbay as well. So we should have a better overview of the young carers within those target communities in the future, because we don't really have a good sense of it at the moment because they're not really accessing our services, our commission services. We have, in Plymouth, we have resettlement schemes relating to Syrian communities and Afghan translators. We also have quite a large established Chinese community and Eastern European migrant community as well. Smaller pockets of other communities in Plymouth, but those are the main sort of groups that we were targeting. In Torbay, they have only 4 refugee families, so it's a lot smaller in terms of the numbers and the communities. So by working together, we had sort of a better chance of engaging with communities and sharing the learning between the two sites. Next slide, please. Okay, so the original aims were about, as I said, engaging with those communities on the first slide, making sure that we co-designed the recommendations with partners to help to not only identify what those should be, but also what support should be available to those carers. And that's kind of an ongoing process. So as we continue to work together and we're continuing to meet on a monthly basis, we're sort of identifying how we could do that better, how we can work together, how we can share resources, and how we can engage that community in a longer term way rather than just during the period of the first phase of Mind Gap funding. Next slide, please. So what we wanted to do, because as a local authority we didn't have direct contact, very good direct established relationships or contact with those communities, we went through trusted organisations, community organisations, and that was the best way of us to to engage with the people in those communities and identify whether they were carers or not. So the first thing was to train deliver some sort of care awareness, young care awareness training to those organisations. So we put together for the first time joint carer and young carer awareness training sessions for targeting those organisations who engage with our communities that we were trying to contact, just so they could identify within the people that they currently support who could be a carer or a young carer. And there were some really interesting case studies that came from that, actually, because the way that certain groups, for example, asylum seeker refugees, are housed is slightly different to other populations. So they're more likely to be in housing which is of multiple occupations. So they have a slightly different arrangement when it comes to caring responsibilities that might be shared amongst a larger group of people rather than under how we normally deal with it in our commission services. It's normally through a family approach. So that was quite interesting to see how we could do that in different ways, how we could understand what caring responsibilities and what caring responsibilities were for those communities and what that would look like in those communities. We also wanted to make sure we had a working group with representation from those partners, so that we made sure that we were engaging them in effective and appropriate ways. We also designed how we would engage with those communities, and that included language translation and contacting at particular points of the year, for example, in the Chinese community, through the engagement that happens as part of the Chinese New Year, which is in February, which fell within this project. So that was quite helpful because there's a lot of activity around that period of time as well. So that was a good opportunity. Next slide, please. So the Torbay ambassadors. So the Torbay ambassadors programs, there's 3 Torbay ambassadors there. And what they do is they train their adult carers to deliver. They train them to become care ambassadors, and those care ambassadors are able to not only support other carers in terms of peer support, but also help other people to identify themselves as carers. And they identified themselves as carers through this engagement process, which was working with Julie, who is, unfortunately, I don't think she's in the room with us at the moment, so she'd be able to give a bit more detail on that. But she ran those women's circles, she ran the storytelling sessions, which was a really good way of us engaging with communities in the way that they are comfortable with. So we would normally send out a carer survey, we'd normally send out which is normally a tick box exercise of a paper survey or online survey. So we started to think about different ways of engaging with communities to be able to get feedback from them in ways that they were comfortable with, and how they could engage with us and tell us their stories, that we could then take that learning and improve our services based on the holistic view of what their experience was, rather than looking at it from a service specific point of view, which is how we tend to normally engage with carers. So we look at it based on, this is a carer service, or this is a health service, or this is community service, and we don't tend to look at it as the whole. So that was a really interesting new approach that we tried with this. There are also going to be some videos coming out of those carer ambassadors as well, so we'll hopefully be able to share that with you, which is where they share their stories with us, and we have that on video, which we can use not only in training but we can share, so other carers can identify themselves through those videos. Okay. We also used a appreciative inquiry approach, which is where, again, about storytelling and getting them to identify their own, open-ended questions, and getting them to share their story with us in a more open way, and then revisiting that to improve the service and the process as we go, rather than just a one-time engagement. Next slide, please. So the plans, as we said, we would normally do surveys. We did do a survey which we incorporated the recommended research template into, but we put the appreciative inquiry, storytelling and listening session at the front of it, so that we had that kind of very open engagement to begin with, and we didn't restrict their responses based on services. We also use pictures. We've got feedbacks that we used for case studies. As I said, we've got videos. We've also got experiences from the local communities based on their strengths as well as their challenges. So we wanted to not only make this about the need, but also about the sort of assets that they have as well. And we wanted to understand why those carers don't access the services that we commission and how we can make those services more accessible. So that's what we're working on at the moment and was part of our recommendations that came out of this. Next slide, please. Thanks. So our partnership working group that I mentioned before, we had a really wide range of organisations engaged and still engaged even now after the project funding has ended. The Racial Equality Council, the Racial Equality Council, we also had representatives not only regional but from the local areas and from Torbay as well. We also have a representation from carers and young carers providers as well as health providers. Next slide, please. We have reviewed, as part of this work, we've linked in with the equality reviews. We've also linked in with a specific ethnic minority engagement project that was taking place at the same time in Devon, across Devon CCG, and we're linking up our recommendations so that where there's crossover with what we have recommended from Mind the Gap and where there's recommendations for the health provision, that we work together on those. And the CCG report has yet to be agreed. So when that is agreed, we'll be looking at how we can deliver those recommendations together going forward, because there's a lot of crossover there. We also want to continue with the awareness raising training. The joint training worked so well that actually we're starting to roll it out to the acute hospital as well. So that's where it's starting, and then we'll roll it out to other partners as well. But we felt that the acute hospital needed some awareness raising, particularly for caring young carers in general, but obviously there will be elements of Mind the Gap incorporated within that now. We're also continuing with the appreciative inquiry training and the fact that we'll be using that approach not only for our assessments, but also for our engagement with those communities going forward. And it's a continuous process, so it's something we hope to do on a regular basis as well, so we don't miss anything and we continue to improve the services that we deliver. We also want to make sure that we're linking in the Mind the Gap work with our governance structures. So we've done that on a local level in Plymouth and Torbay, and we've also got a link in with our Devon Carers Leads meeting as well, which is our group that we meet across the STP, the CCG footprint, the ICS footprint in Devon. We've also got a link into the Devon, the dental school, and they're looking to set up a asylum seeking clinic, and also we've delivered training to them, but we've also looking at getting those dental students from that school into the young carers service, where they're going to do their community placements, and that's going to be starting in September. So they'll be placed for I think about 3 months within the young carers service, and that's the first time that's happened between the dental school and the carer services. That's really exciting, and that's come directly from this project. And again, the annual school survey and rolling that out across Torbay as well. Next slide, please.
Just to say, there's about 1 minute.
Yes, so...
Sorry, there's just about 1 minute left.
Okay, so I think I said this. Okay, so there's peer group mentoring. I've mentioned the videos already. We're also developing a bespoke health ESOL course, where this is again what's come out of the Mind the Gap, where people wanted to have the vocabulary to specifically engage with health services, rather than the basic ESOL course that is delivered at the moment. So we're looking to develop that, and that will be again across the Devon footprint, rather than just specifically in Plymouth. We've talked about the digital storytelling. We're also looking at embedding Mind the Gap awareness into our employability programmes, And again, the ambassadors programme, we're looking to not only build on that existing programme from Torbay and the learning and take that across to Plymouth, but also we're looking at seeing whether we can recruit people from wider groups within those communities listed. But those actually people from those communities have been starting to engage. So we've seen as part of this project, and just by the promotion and awareness raising, we're seeing more people from those communities starting to engage with our commission services. So it's already starting to make a difference. Next slide, please. And these are just three things we do differently. In terms of the equality monitoring, we didn't have any representation from the LGBT community, so that is definitely something that we would want to link up with the organisation, the local authority that is doing that specific project, the local authorities that are doing specific projects for those communities, take the learning from that and how we can carry that forward in the next phase. And also just making sure that we wanted to engage more with young carers on a face-to-face basis, because that would be the best way to do it. And we've got plans in place for how we're going to do that moving forward as things start to open up again. Next slide, please. Findings. So yes, so we need language assessments. We need make sure that the communication channels there. The most important thing out of all of this was building relationships and trust. That was the most important thing, to be able to access the communities and gain their trust in order for them to feel comfortable when coming to us for support and help. So that was a real biggie, and not to be underestimated. Again, cultural barriers, cultural sensitivity, and how we approach different communities in the way that is appropriate for them. Next slide, please. Recommendations. So this is from our report, which you'll be able to see. Working with partners, making sure that we obviously engage with the wider group. So, for example, Gypsy, Roma and traveller communities. We also want to make sure that we engage better with the multi-faith groups, which we didn't do as well the first time. And we also want to make sure that we, like I said, continue the care awareness training, continue to build confidence, continue to share awareness, and build on further into the health providers as well. So the acute hospitals, as I've mentioned before. We also want to include substance misuse, mental health and dental services, which we're starting to do already. And also look at the legal statuses for carers and making sure that everyone's aware of what people are entitled to. Next slide, please.
I'm just going to have to stop you there. I'm really sorry, just to allow the others to have time to present. I'm just conscious we'll get chucked out of our breakout rooms without me having any control on the matter. So thank you so much. There's so much great work that's happening. As I said, the examples and the case studies and your appreciative inquiry approach is all available on the Futures platform. So hopefully people can go there, and they can, if you're happy for them to keep asking you questions in the chat box.
Yes.
And there's lots of positive reflections, so thank you so much for that. Hayley, are you all right to go to the next slide? So I'm hoping that Tom, I think there's an issue with Tom getting into the room, but I'm hoping that Gemma is here. Gemma, if you're here, are you able to unmute yourself? Just check on the participants.
It looks like Steve's about to move Tom in now.
Saved by the bell.
I thought I was going to get away with it then.
Hurrah! You're here. Welcome, Tom.
Can you hear me?
Yeah, I'll hand over to you now.
Thank you. Thanks, everyone. Yeah, sorry about that. I was placed in the wrong room there for a few minutes. So let's see if I can hit the ground running and tell you a bit about our work in Brighton and Hove in the last 6 months or so. We were very fortunate to be awarded Mind the Gap funding, and we decided to engage with carers from a variety of different communities. And I'm aware that many of our colleagues have focused in on one particular group of underrepresented carers, but we consulted with carers from ethnic minority backgrounds, from the LGBTQI community, and also the GRT, Gypsy Roma Traveller community as well. The reason why we wanted to cast our net quite wide in that regard is that around about February of last year, we employed our very first inclusion and support worker, whose task is to support and engage with carers from all of those groups. So we wanted to cast the net quite widely in seeking their views on barriers to accessing services and what would work with them. The methods that we used to engage with carers during our Mind the Gap scoping project were pretty standard, really, I suppose. We had a survey that was with around 140 carers invited to engage in that. We then ran focus groups and followed up with one-to-one case studies where whenever attendance was not quite as we'd hoped. And then we also had translated versions of and paper copies of our surveys in a variety of languages you can see on the screen there. Next slide, please. So of our survey questions, we had some demographics ones. We wanted to ask about support that the carers currently accessed, their experiences of accessing that support, ideas for us as a voluntary sector organisation, what we could do to engage more people from their communities in the future, and any services that they require whilst accessing their support for the cared for person. So, for example, in Brighton and Hove, we have a scheme called My Health Matters, where if a carer needs to attend a wellbeing or health appointment themselves, they're able to get cover from a paid carer service, and that's a funded service. So we were trying to seek information about support they would like in the future, and just gauge how aware they were of existing provisions in the city. Next slide, please. There you can see a little bit of a breakdown of the proportions of people that engaged with us. Quite a high, when you consider that we were engaging with multiple different groups, the respondent rate was probably highest proportionally amongst our LGBT community. And perhaps the reason for that is that you may well be aware that Brighton and Hove is a well-known, diverse city in regards to sexual orientation, and we had a little bit of a leg up in that regard. We have a bit more of an established foothold in supporting carers from that community, as opposed to other underrepresented groups. So that's why those stats are a little higher. Next slide, please. So, as mentioned, we were looking to find out if carers had experienced good practice within their existing healthcare provisions, whether there were any barriers that they came across, and what their input was in regards to removing those barriers. How can we make services more equitable? Not just looking for equality, but also equity, so that really, rather than having to give particular carers extra help, we can set up things at a systemic level so that people can access them without needing extra help, if you see what I mean. Next survey slide, please. So in regards to responses, we had 18 from our electronic survey, a further 6 from our paper forms, and we held 3 focus groups. As you can see there, we followed up with some additional one-to-one phone calls with some of our Gypsy Roma traveller carers. Yeah, good level of depth from the contributors that were involved, even if we would have liked to get a few more respondents overall. Obviously, pandemic restrictions impacted upon our ability to do so, because we had hoped to do some in-person events, particularly at the local traveller site. That was a hope of ours prior to being awarded funding. Next slide, please. So yeah, as mentioned, it's been a challenge, as I'm sure you're all aware, to reach people during the pandemic who are not digitally engaged. That said, we were able, through Mind the Gap funding, to provide a number of carers with IT devices, and through our volunteer scheme, our reablement project, we were able to upskill many of those carers in becoming a bit more familiar with things such as Zoom and other video conferencing. So some of those carers were able to participate in the Mind the Gap focus groups, which is great. Another thought was that, given the timing of the project, I believe we started in terms of the planning stages around about Q3, so October. Of course, it was then a bit difficult to arrange focus groups and survey returns around the holiday period. Often, you know, it's a time for all of us where we're extra busy, and that's particularly true of carers. So that was a few of the challenges that we faced. Next slide. So some positive key points that came out of our correspondence with carers, that third sector services in the city were largely viewed as credible and important to carers, as were emergency services. A bit of a mixed bag in regards to different carers' individual experiences. Obviously, a lot of factors around large healthcare services or social care. Sometimes it is a bit dependent upon which worker is assigned to you as to what your experience is going to be. But many services within the city were praised by carers on an individual and a collective basis. And so we did have some really good positives to come out of it about existing carers' experience. Next slide, please. Some of the biggest challenges that came out and for carers, those that were cited most frequently by our respondents, were challenges around making GP appointments. Bear in mind, again, we're talking about a time around sort of 6 to 8 months ago, when when it was quite a challenge to make GP appointments. Obviously, in-person appointments were very much restricted. And that only compounds challenges that people face, for example, when English is perhaps not their first language. There was a general feeling that initial contact and assessment type services is often quite good. And for our part, we do have a small level of funding to provide translation and interpreting at those initial assessment stages. But as just speaking for one service, we don't have enough resource in that regard to provide that on an ongoing basis. And so that can lead to carers feeling as though more regular proactive help is perhaps not there. It's almost like you get an initial kind of flurry of activity, signposting, etc. But then it feels a little bit like the ball's kind of left in their court, really, which doesn't work for everybody. Obviously, very common response, again, due to the timing of this research, was around the experience of carers during the pandemic. So exponentially more loneliness and isolation and anxiety during lockdown and that sort of thing. The final bullet point there is an interesting one. We found that many carers that we spoke to felt as though the term carer was being lost to them. Maybe people confused it, perhaps more now than ever, with paid carers or NHS staff when they hear the term carer. Many people in recent months thought of initiatives like the Clap for Carers, which is obviously really important to acknowledge and praise the amazing work of NHS and other paid staff. But of course, that leaves our unpaid family friend carers somewhat left out. And as I say, many of the respondents that we worked with said that they felt like they were being a bit forgotten, that the term carer was being used for other sort of categories of people. Next slide, please. Other experiences include these are some more kind of more individual comments, so I won't go through all of them, but having a constant battle, having to fight for everything, needing that recognition that as a carer you should be part of discussions around the treatment of your loved one, the sort of intervention package that may or may not be offered, and ensuring that carers are a part of that. And again, it can come down to bad experiences versus happening to be assigned a caseworker or a clinician that's understanding of carers and their needs. And yeah, I mean, there has been challenges faced by almost all of our respondents, with only 10% of them suggesting that there were no barriers to accessing services when they considered the underrepresented community that they came from. Next slide, please. I think we'll be going on to some recommendations here to round things off. So
just 2 more minutes, if that's okay.
Yep, lovely, thank you. So this, I think there's this and then one more slide. So this first one is the recommendations that we ascertained that could be directed at local carer services like our own. So these are the things that we're now trying to work towards developing. So we're looking at models through which we can seek additional funding and resource to be more proactive, as I say, rather than waiting for carers to call us. So looking at kind of opt-in services where carers can choose to receive regularly scheduled check-in calls, even if there's nothing really specific that they need to update us on. As mentioned, many of our respondents said that they would appreciate a bit more of that longer term periodic support. We're looking to offer more of a suite of translation and interpreting services and strengthen our existing partnerships with local translation services like Sussex Interpreting Service. Providing info in alternative formats. So since this project's completion, we have actually published much of our core literature, leaflets and so forth in 5 or 6 different languages in response to the research that was carried out under Mind the Gap. And improving the provision of ongoing specialist support for dementia carers. This was really important evidence that we've used quite quickly to go back to funders and tell them about the demand for specialist support for dementia carers. And in response to us taking our findings to funders, we've actually been able to increase the funding for our memory assessment service link worker role. And that position has moved from being just 1 day a week up to 2. So that's been a nice result for us. And then if you go to the final slide for me. So these are recommendations for NHS services that we'll be working towards with our local integrated care system. A bit more effort to engage a wide range of carers in patient participation groups would be welcomed. NHS staff using clear, accessible language, less jargon, please. Ideally, carers would like shorter waiting times, of course, and there's a big demand on mental health services, more so now than ever as we hopefully emerge from the pandemic. And more understanding required for LGBTQ families wanting to have children. That was cited by a couple of our respondents as well. So yeah, so some recommendations there, both for the third sector and for statutory services that we will be hoping to embed in the months and years ahead. So I think that's my last slide.
Thank you very much, Tom. Really appreciate it. And we'll be circulating the slides. The other thing that's come up a little bit in the chat is around the LGBT Foundation, and GADM also did some work on this in Greater Manchester. So that's available on the Futures platform as well. So interesting to look at the kind of similarities and differences in thinking about rolling similar things out yourselves. We're going to go, if you go to the next slide, Hayley, we're going to go to a break. But if you're all okay to stay in this room, I'm happy for you to kind of go on mute, turn your cameras off, and then we'll hear from South West London Health and Care Partnership and Birmingham and the West Country after the break. And if you're okay to come back in 5 minutes, that would be wonderful. Thank you, everyone.
Hello, everyone. So it's 2:30. But I realised we had a slightly shorter break. by slightly shorter, I mean half of what we should have had. So apologies for that. I'm going to start talking, and I'm hoping that people will just, you know, like a siren song, they will gravitate back. So same intro as before. Basically, we're still recording. I think hopefully you're still stayed in the right room, and Steve hasn't been sort of messing around with us for sport. I don't think he has. So yeah, we're still recording. If you've got any questions, as the speakers are going through their presentations, please pop them in the box, or if you've got questions about anything, pop them in the box. We will try our best to get them answered here and now, where they need answering here and now. But if not, don't worry, because one of the reasons we're recording is so that we can answer all the questions afterwards. So we'll do a Q&A sheet. So without further ado, hoping that everyone has made their way back, we have Paula and Andy from Southwest London. Always welcome. And they're going to be talking about the work they did with people with learning disabilities around digital poverty. Can I hand over to you, Andy?
Thank you very much. Yes, good afternoon, everybody. Very nice to be with you. Been very much looking forward to speaking to you about our project and our work. Just by way of preamble, many people will be familiar with the name MenCap or know MenCap. We're Merton MenCap in Southwest London, a charity supporting people with a learning disability and their family carers. As I say, our area of operation is this London borough. Now, as many organisations did at the start of COVID, we had to adapt our services in line with what the government was saying and the restrictions, and we moved many of our activities to continue online. And that brought into sharp focus whether people would be able to accept those activities that we ran online, whether they'd be able to key into them and receive support in a different way. And we felt that not everybody could. So we were very keen to do a research piece which analysed the problem of digital exclusion, digital poverty for our care group. Next slide, please. I won't read all of this out, but this gives you some context with the work that we carried out. The audience is 3,000 Merton residents who have a learning disability, and most live with their family carers. And we're in contact with a great many of them. And according to the UK Consumer Digital Index, 22% of the population have basic or no digital skills. Now, Merton MenCap are aware of many individuals who struggle with digital access, and we needed to understand better the scale of the problem, the extent of the problem, the barriers that were preventing people from receiving support digitally, and the impact on digital exclusion on family carers and their ability to cope under very difficult circumstances. As we know, family carers have always had to cope under very challenging circumstances, but it was exacerbated by the COVID situations. And what would be some solutions that would have a long tail to them? In other words, not just addressing the problem now, but that would really produce solid outcomes for this care group. Next slide, please. So I think at this stage, what I'll do is I'll hand over to my colleague, Paula Jewis, who carried out the engagement work to explain our approach to it and our findings. Paula Jewis.
Hi there, everybody. Yeah, I mean, we've summarised, these slides are very summarised. You can read, I think, the full report somewhere, so it gives you a little bit more detail. But we were, despite the problems of COVID, we offered, you know, a range of ways to access our carers. All the ways that you can imagine were legal. So we offered face-to-face walks outdoors. We offered we explored using partners, so people people were seeing face to face. We asked them to do this bit of engagement work for us. So day centres, for example, for people with learning disabilities, they contacted people for us. Social workers contacted people for us. And we used the parent forum, which we have, which actually Merton Mencap hosts. So we have a sort of very strong link into our caring community of people with learning disabilities. So we used every possible form of engagement and every possible form of advertising to try and make sure that we accessed carers who are both digitally enabled but also digitally unabled. We had to work with carers who were able to access digital, because we aren't just looking at digital exclusion, we're also looking at digital poverty, which means that you might access things on the internet but in a very limited way and are not making the most of it. So for example, there are carers who can easily access email and WhatsApp, but if the NHS were to put up an app which required them to use that to access primary or tertiary care services, they wouldn't know how to download that app. So we needed to explore like quite a lot of complexity around that. And yes, you'll see in the report, we also found that the profile of internet usage was different between the carer and their cared for person. So the cared for person would perhaps benefit more from entertainment use, but the carers very rarely use the internet for entertainment use. So we weren't just looking at, you know, are you able to be online or are you not able to be online? Do you need a laptop or don't you need a laptop? It's a question of how do you use digital, and are you able to use digital in a way which you need to use digital, or which would have the best benefits for you of using digital. So another area where we were looking is things like saving money on things like electricity or online shopping, whether people were able to use that, or if carers, by being a digitally excluded group, are actually costing themselves more money and making themselves more vulnerable. So we looked at you know, the whole aspect of this. Next slide, please. Is there another slide? Is there another slide to go? Oh, there we go. Yeah, we did have one stumbling block, which is that there was quite a lot of engagement going on. So we weren't able to send, we were able to send lots of letters out, but not via the social care team. So it sort of slightly limited our access by possibly about 100 people. Okay, next slide. So we overreached our target anyway. We reached 66 people, and they were quite well spread in terms of where they lived, and whether they were joint caring or sole caring, or whether they themselves, quite a few of course have a disability or impairment themselves. And not surprisingly, 82% report that their caring duties increased during COVID. By a significant number of hours, actually. There are a group whose caring duties decreased during COVID, partly due to the fact that a cared for person remained in their supported living home instead of coming home at weekends, or some people actually did have to move out into residential care because carers couldn't cope during COVID. Next slide, please. Okay, so the outcome was that our care group were 32% digitally excluded in broad numbers, compared with the 22% that Andy mentioned at the beginning, which is the national figure for everybody in the UK. So we discovered, yes, that our care group is digitally excluded. We also looked at what the risk factors were for digital exclusion, according to the national survey that happens every year, commissioned by the government, which is run by Lloyd's. And all the risk factors, apart from one, I think, apply to carers. So it isn't surprising that carers, and indeed their cared for persons with learning disabilities or autism, are I think possibly the most digitally excluded of groups, in fact, because they meet 5 out of the 6 criteria. Things like living on benefits, and you know, things like being a female, that makes you more likely to be digitally excluded. Being older, above 50 and particularly above 70, makes you more likely to be digitally excluded. And the carers of people with learning disabilities who are adults tend to be in those categories. So what we looked at now is why are they digitally excluded, and we found these 6 main barriers. One is the motivation, especially the older group. I've not used the internet so far, so why would I need to use it now? Then there's the understanding that things like it's very hard, I need skills that I don't have, or that for some reason there's a barrier in terms of language, which of course is the opposite. The internet is a way of automatically getting translations. That's very poorly understood. Lack of exposure. So our carers see people using the internet in very complex ways, for example on TV, and they don't realise, they don't see other people like them using it for the purposes for which they would be using it. So for example, using it to switch providers, or using it to access things with social care into conversations with the social worker. They don't see that happening, so they're not really aware of why they would need to go to all that effort of buying technology and signing contracts and all that stuff in order to get internet access. And there are also practical considerations. Well, okay, I need internet access. Well, how do I do that? Do I just need a phone, a tablet, laptop, PC? What price range? How do I set it up? Do you just plug it in? So how do we do that? And we found that there were some charities providing reconditioned laptops, which were proving counterproductive because they couldn't download the things they needed. They didn't have enough memory. They weren't working very well. Screen wasn't good enough. The additional access that they needed were not able to be loaded up. So there was that element. We also found there was just a fear of looking old-fashioned by not being able to do it, and having someone teach you and then not remembering what they said. So fear of failure, and also a perception that they would be exploited online. And then there was also the financial side. Okay, next slide, please. So what we realised is that you need to understand each individual barrier in order to move someone to become online. We also realised that some carers will never become digitally included because the barriers are too great. So we can't set ourselves a target of moving all carers to being online carers. So we have to have a digital strategy which includes a person-centred approach to this, understanding individual motivations, understanding that success does not mean 100% carers becoming online, so we will have to continue other methods of engagement. And also we discovered as part of this that social workers and other professionals who see people in their homes do not themselves feel very able with regard to digital, in particular in regard to increased access, so accessibility programs for people who might be visually impaired or need bigger keyboards, or voice to text, text to speech, that kind of thing. So they felt vulnerable because they are not able to advise the families that they're visiting about how to change to become more digitally included. So that led us to these 3 strands. One is an awareness program, another is an overall digital strategy and how to do this in a person-centred way, and another one is a specialist training for frontline workers to enable them to become digital facilitators as part of their role, because digital is becoming more and more fundamental, especially as the NHS and government put more and more online. Being online is almost becoming a human rights issue. Therefore, it really needs to be embedded into things like our understanding of the Care Act and our training for social workers. So those were our key recommendations, and I think that's the end. Is there another slide, or is that it? No, that's the end. So thank you for listening, and I'll scrutinise the chat and see if there's any questions anyone has.
Thank you so much, Andy and Paula. That is a really, really interesting project, and it's so relevant going forward because, as you said, Paula, we're not kind of going to go back, and there needs to be a mixed model. So it's really interesting work. Thank you, and I would really encourage people to have a look at the report on NHS platforms and the case study. So I'm very much hoping that Callie from Birmingham is with us. Well, I say Callie from Birmingham.
Yes, I'm on the call.
Lovely. Welcome. Thank you so much. We are running slightly behind, but don't let that worry you. We look forward to hearing from you.
Thank you. Hi everyone, I'm Callie Judge and I'm the engagement specialist for the Black Country and West Birmingham Clinical Commissioning Group. Can I have the next slide, please? So previously we were known as Sandwell and West Birmingham Clinical Commissioning Group. As of the 1st of April, we've now become a Black Country and West Birmingham Clinical Commissioning Group, which is made up of 5 places for those of you who are familiar with the Midlands. So the map indicates the 5 places that we represent: Dudley, Walsall, Wolverhampton, West Birmingham and Sandwell. We're also part of the Black Country and West Birmingham Integrated Care Partnership, which is made up of a range of stakeholders such as local hospitals, mental health trusts, primary care networks and community providers. Can I have the next slide, please? Thank you. So in terms of our chosen target audience and why, we focused on the Black, minority and ethnic carers who are looking after a loved one with a learning disability in West Birmingham. And the reason we went for this group was because Birmingham has high levels of deprivation, with 40% of the population living in the top 10% of the most deprived areas in England. 42.1% of the population is made up of Black, minority and ethnic groups, whilst the national figure stands at 15%. 72% of the population is predominantly young, that's classed as 45 or under. The life expectancy in Birmingham is lower than the national average for males. It's 77.2 years, whilst the England average is higher at 79.5. years. For females, it's 81.9 years and the England average stands at 83.1 years. In terms of the statistics we've had from Forward Carers in Birmingham, they estimate that there are 107,380 carers living in Birmingham, and it's predicted nationally that as care needs increase, the number of carers is estimated to more than double by 2030. We know that some carers do not feel confident accessing support from NHS services, which means that they may experience poorer physical and emotional well-being. There's clear evidence from sources such as GP Patient Survey and the State of Caring Survey that carers face inequity as a result of their caring role, suggesting they are twice as likely to experience poorer health compared to their non-carer peers. This is often contributed to by lack of appropriate, accessible and culturally relevant information or support, finance concerns, stress and social isolation. If I can have the next slide, please. Thank you. So with my presentation, I focused mostly on pictures. In terms of the sharing what went well, the actual magnifying glass indicates the mapping exercise that we undertook with 2 of the biggest umbrella organisations that have the links in Birmingham, and they're known as the Birmingham Voluntary Service Council and the Birmingham Carers Hub. We also used the Route to Wellbeing, which is a directory of local voluntary sector services in Birmingham, to map services. And by carrying out this mapping exercise, it helped me to identify organisations that support Black, ethnic and minority carers who were looking after a loved one with a learning disability and living in Birmingham. So once that scoping exercise was undertaken, the next thing was to actually hold a co-design workshop. So this co-design workshop took place in December, and these organisations were personally invited by telephone call. And we actually had 6 local carer organisations that actually fitted the bill in terms of supporting this cohort of carers. and 4 caring organisations actually came on board to support us with the engagement. 1 wanted to but couldn't because they'd lost quite a lot of staff as a result of COVID, but still wanted us to bear us in mind for future engagement exercises. So essentially what this workshop did was it presented an opportunity for local organisations to hear about the NHSEI Mind the Gap programme and for us to learn if they were interested in collaboratively working with our CCG and co-designing an approach and methodology to support us to measure and evaluate what matters most to carers and what barriers they faced when accessing health services to manage their health and well-being. This gave us an opportunity to develop links and partnerships with caring organisations in West Birmingham that already had the trust and relationship with this cohort of carers to support effective engagement. As a result of the workshop that we held, it allowed us to co-design a survey and a case study with the interested organisations because they recognised that not one size fitted all, and they wanted to be flexible in how they carried out the engagement and capturing those experiences such as case studies, focus groups and one-to-ones. So a draft set of case study and survey was developed and approved by the interested organisations. So once that was finalised, our engagement window was a 6-week window which commenced on Monday the 11th of January and ended on Friday the 19th of January. So essentially the identified caring organisations which were interested in working with us actually carried out the engagement during that window, and they managed to engage with 54 carers through a survey and 5 carers through a case study, and I carried out 1 case study with one of the caring organisations. In terms of the check-ins, I made myself available once a week to do a weekly check-in phone call with each organisation to see how things were progressing and to see if there was any issues or if they needed any support with anything. In terms of the money changing hands, the really good thing about this project is we didn't actually keep any of the money. We were able to incentivise the sector for their time and efforts. So we actually agreed a funding mechanism whereby the caring organisation received some money to undertake the engagement with. So there was a set fee for doing a one-to-one survey. There was a set fee for carrying out a case study, which went directly to the organisation. But there was also an incentive to the carer to take part in the engagement as well. And that also factored in setup costs and also translation costs as well, so that they were rewarded appropriately for their time and effort. So if I can have the next slide, please.
Hello, Callie. Sorry, I'm so sorry, but we've probably got about another minute and a half or so.
Yeah,
I would hate for you to get sucked out the room.
Yeah, no, I'm nearly there. That's fine. So in terms of what 3 things would we do differently? If we were starting again, the timing may not have been great to engage with caring organisations and carers during COVID pandemic because COVID was the priority, and most organisations either offered a limited service or closed off the face-to-face support groups to comply with social distancing. Some time was lost over the Christmas holiday period, which may have allowed for a longer engagement window, as most organisations shut down for 2 weeks during this period. And as always, it's always good to have more time to undertake the engagement, because in turn this may have allowed the organisations to engage with this cohort of carers. Can I have the next slide, please? In terms of understanding what matters most to carers is looking at the person holistically, considering their mental health and physical health, rather than them just being a number. Having someone to talk to, such as other carers, to support each other and share their experiences. Having me time, such as attending activities and support group sessions that are culturally sensitive and consider language barriers, socialising with friends and family and having respite breaks. Information on what is available to carers and how to access it, such as financial support, health and wellbeing support, receiving coordinated and integrated care through health and social care for themselves and their cared for person, as this creates a lot of stress for carers. Social isolation for carers. This has worsened during the pandemic as most support services are either offering a limited service or shut down to comply with social distancing guidelines. In terms of the key learning from this project, it's about involving the right people at the right time and selecting those caring organisations that are closer to the carers than what we are. We do also have about another 2 or 3 slides, so I don't know if I'm going to get round to those or not. Can I have the next slide, please? Thanks. So in terms of the recommendations, each GP should have some level of engagement with carers to understand what matters most to carers so that improvements can be made in this area. Having dedicated care navigators to help carers navigate services and highlighting what carers are entitled to and how to access them. Awareness and promotion of how to register as a carer and what carers can access and are entitled to. Awareness of promotion of learning disability health checks for the cared for, capturing feedback on learning disability health checks from carer and the cared for to make the learning disability health checks more informative and user friendly. Information for carers to be available in a range of formats to address language barriers. Closing the engagement loop and providing feedback to the caring organisations and carers who took part in the engagement to say what we have learnt and how their experiences will improve and shape the carer support offer in the future to demonstrate that you said we did. The caring organisations who attended the workshop did ask what their contributions would actually influence, and also inviting representatives from Carers UK, General Practice and those that took part in this engagement to be part of a wider local, regional or national co-design carers group, and for this to be reflective of the ethnicities that we serve. And then we've got the last slide, which I could probably do in about 30 seconds. In terms of the benefits of this programme, it provided a great networking opportunity to meet other sites and learn about their projects. Attendance and commitment to online learning events and sharing that learning and picking up on hints and tips. And I think I was delighted that we were picked as one of the 3 sites to be externally evaluated by the Liverpool John Moores University. And then last slide was just questions, if we've got time for any.
Thank you so much, Kelly. I'm really sorry that I put the rush on you there, because we then got told we've got a stay of execution.
Okay, thank you.
So, but that is marvellous news that you didn't get cut off. I'm so glad, because there's nothing worse, is there, than being sucked out of a room against your will. Thank you. That was really, really interesting. I'm just keen to know, are the relationships, do you feel that you've sort of started something now that will continue onwards in terms of relationship building?
Definitely. I think the mapping exercise really helped. I think having the co-design workshop, building up those relationships. And I think the fact that we were going to be externally evaluated, I had the chance to sort of do that warm handover with the external evaluators and the organisations rather than someone just going in cold. And as a result of that, they work quite closely with the John Moores University. So I think definitely, and it would just be good to build on that and see where it goes.
Brilliant. Thank you very much. I should have been keeping an eye on the chat for questions, shouldn't I? Does anybody have, I mean, we know each other now, we've been in the same room for almost an hour or so. If anybody wants to sort of shout out a question, please do feel free, or stick your hand up if you want to be more formal. Nobody minds. I'll pop it in the chat. I think we're about to be, Verity, are we about to be sucked out of the room? This is very unnerving.
I know, I think so. We've been given extra time and now
it's very
sure
unnerving.
it's a work in progress with so many people. I imagine it takes a little while to think about what it's doing.
It does. Sorry, I'm just looking. There's a question. Are you bringing us back, or do we have to leave? So, what I might do is wait for the answer to that one.
Oh,
no, we're going. We're going.
See you soon. Thank you, everyone.
Thank you so much, everyone. See you in the big